Hi everyone, welcome back. Are you all tuned in? Please let me know if you are all tuned in. And if you are able to hear me clearly. Very good. Does everyone have the popcorn? Do you have your popcorn for today's show? Okay, I'm planning to make you all entertained and to get the fear out from the exam regarding the thyroid. One thing I did forget to tell you last session that there were some exams in the last 10 years where the thyroid came twice in the short surgical. And this was a bit of a surprise. The thyroid is a must-have case in the cytology. So out of the 8 cases that you will get in the cytology exam, you will have a thyroid case, and then that will be either, which is usually the case, either the case in the cytology will be a proper papillary carcinoma, or it will be Hashimoto thyroiditis, or a completely benign, like hyperplastic nodules that's a little bit more cellular than usual. The college don't tend to put the Thy3 category in the exam, and that apply for almost all the cytology cases. So in the cytology cases, we would expect you to favor something, and then there will be, yes, 1 or 2 scenarios that you might need to put benign versus malignant. For example, if you get a florid mesothelial proliferation in a pleural effusion, then you may wanted to do that differential, but you still have to favor, if you feel that this is more of mesothelioma, for example, or if this is a benign florid mesothelial proliferation rather than being malignant. So this is, but the thyroid, so going back to the thyroid has to come Thy2 or Hashimoto thyroiditis, or basic lymphocytic thyroiditis, which should be categorized for the college and for the sake of the exam as a Thy2, and which is the THY2. This is the classification that we use in the college. I am just reminding you of that. And then the Thy5, which is the papillary carcinoma, which can come quite frequent in the cytology. But for short surgical, as I told you, it usually ends, you will end in one case in the short surgical, doesn't come in the long surgical. And in England, we don't do frozen section for thyroid. I am in the process of preparing a big talk for you guys for frozen section, which will, but for that one, I have to prepare slides and things because we will need to have some tables and a lot of other things. So this will be coming soon. I think maybe we are talking about roughly 10 days. So for those who are setting the exam soon, don't panic. I will definitely give you the frozen section soon. And I will also give you the OSPI station, the written OSPI, all of those sort of things. We will make possibly a sessions about the clinical scenarios and the written OSPI, so you will also be up to the ready. Of course, if you wish, we can do one quick session for macro to prepare for those who are eminently going for the exam. But in the future, I will be doing more comprehensive sessions for macro and for those who still have time to study and save for the exam. Before we carry on with the thyroid, I promised you that I will collect for you some of the vascular invasion things that because of after the talk that we had before. So let me just show you some of the we will just go through the vascular invasion again, because I know it wasn't very clear sometimes, and sometimes the pictures mean 1,000 words. So I will just remind you what I have just quickly said, and I will show you examples, and then you will be fine with that, I'm sure, in the exam, and maybe in real life with more depth. But if you have a blood vessel, so let me just use the annotation as well. So just remind ourselves with what we've said last time. If you have a blood vessels that even has got a tumor or a bulge of a tumor going inside into the vessels that intratumoral, like inside the actual mass of the tumor, not in the capsule, then this is not in lymphovascular invasion. We talked about this, that if you have, and we compared this with that we said that if you have some clusters of cells that are like that, lined by the endothelium all the way around, either in the capsule or outside the capsule, then you will consider those as a positive for lymphovascular invasion, because the endothelium will line this tumor. The only reason why you don't see the connections to the wall, because it just didn't come in the cut where the section was taken. But this is very similar to that. So in some, which is not common to see that you see the tumor just going all the way, penetrating the blood vessel wall. So you see that the endothelium now has been interrupted by the tumor cells, but yet the tumor will go inside the lumen, and it has to be lined by endothelial lining in order to consider it invasive. The only situations where you don't need an evidence of endothelial lining around the tumor will be when you see fibrin deposition around the clot, and I will show you an example of this in a minute. And this one is no, you see, although a lot of people I have seen in my service, in my referral service, that they send cases for which they will call this as invasion, and I always will turn this down, unfortunately. Okay, so I hope that this is clear, and then I will move to some examples. So this is an example here. What you can see that there are tumors. So you will see tumor, which is just going into what you might feel is a blood vessel. And a lot of people might call this as an invasion. I will not call this invasion until I get the endothelial markers. And if I get endothelial markers around this invasion into the vessel, into the tumor here, then I will consider this okay, it's invaded, it's gone into the vessel, that's absolutely fine. So this is one, example of that. Okay, so this is here a better and more clear example. Sorry, oops. Sorry, it just was lagging a little bit. Let me go back all the way back. Here you go. Yeah, so here you can see that tumor is coming out into what we would describe as a vessel. There is endothelial lining into these vessels, very clear and very crisp and nice. So the tumor is coming out, but you can see now that the vessels has now start to endothelize this tumor, which is attached to the vessel wall. Look, you still have to pay attention to this corner, which is the most important and diagnostic corner, because you still have to see the wall of the vessels, which is here. You can see the endothelial cells, just go walk with it, and you see it going all the way around here, and then you were able to see the endothelium is here, but also the endothelial start to line this tumor cell that's gone into the vessel. So yes, I would buy this as a perineal invasion. This is, here is another example. So let me just go through that here. Now you have attachment to the wall, and majority of the textbook will tell you, okay, if you have a tumor in the cavity that go attached to the vessel wall, then you would consider that this is an intravascular invasion. Yeah, that's absolutely fine, and that's absolutely correct. We cannot argue with that. In actual fact, the main criteria and the mother of all is when you get a vessel that's attached, the invasion, the follicles are attached to the vessel wall and they are inside the vessel wall. That is absolutely and utterly correct. I'm sorry, it's just my screen freeze. This is why it keeps jumping again when I do that. So let me try again to go to the next slide. Here we go. So this is the next slide now. What I am trying to show you here is another example of this problem. Now, you have the blood vessels again here. You can see beautiful and fantastic endothelial lining. And then you can see follicles that is pushing into the wall. Yes, they are kind of, there is a still endothelial lining. You know, if you are to do the endothelial stain, CD31 or 34, you will find the lining, but this is more pushing rather than protruded and invaded, where you start in the real one, like what I have shown you in the example. This corner is very important because for me, this is only pushing into the cavity. This did not invade into the cavity. And if you go back to that diagram, you will see that the authors of the diagram almost always will give you some endothelial lining beneath the mass that you see within the vessels, as well as on the surface. And this is the concept that we try to highlight into this here. So again, this is another, this is a nice example, very similar to the last case from last week that we saw or we started with in review of the cases that came in the exam. And what you are able to see in this case, and this is the problem, this is the biggest one in terms of problems that I see. A lot of people call this as lymphovascular invasion, simply because they imagine that this is tumor going into the wall, and this is all plugging the blood vessels, and this is a vessel. But in actual fact, that's wrong, because the vessel is this. And all what is happening here, that the vessel has been compressed by this intracapsular island of tumor that is not full thickness yet, but it tends to be compressing the vessels and make the vessels now start to look a little bit funny. Now, if you if you start to see a very funny looking vessels, like as you can see, a little bit dilated here, normal caliber, and then start to change the caliber in the cut, just think again and think 2, 3, or 4 times if this will represent a lymphovascular invasion or not. We see this a lot in the follicular adenoma, and we discard it. But if you are in doubt and you don't have a lot of experience in this area, then by all means, I will suggest, of course, that you do your vascular stain, and in that case, you will find that the plug is not lined by endothelial lining, while what you will see that this endothelial lining, of course, will catch up the CD31. It is very easy to sort it out on CD31, but some people, you know, have got this very hot blood inside the stream. They don't want to wait for anything. They think, oh, I think it's a lymphovascular invasion. It's a lymphovascular invasion. I am not going to waste my time with that case. And then they end in calling it lymphovascular invasion. And then what is the problem? The problem is that they call for follicular carcinoma rate will be getting higher and higher, and this is a problem. Again, this is another nice examples. It is very classic of this tumor thrombus that's attached to the wall, and what you are able to appreciate here is that you have, of course, the attachment is very clear here, but if you follow the endothelial lining, now you can see that the endothelial lining, how it is surrounding the entire follicles, even without immunostain. You are able to appreciate the endothelial lining in this fantastic example, and I think this will stand for us as a lymphovascular invasion, surely. I'm just moving to the next slide. Here we go. This is another example. Again, even in this example, this is very similar to the example that I've just shown you a minute ago, that what tends to happen in sometimes you can start getting these papillary projections that can happen inside the vessels, and these papillary projections, when we see it in the bloodstream, we always think that this has to be invasion, because this papillary hyperplasia, when it happens inside the vessels, that should not happen really, but it's a phenomena. It has been described before by Rosa. I only knew about it recently, but this is one of the phenomena. But nevertheless, you can see that this is a vessel, and what you can see here, that the tumor is quite attached on either sides to the vessel wall, especially on this side, and then you can see the endothelial lining, and you are able to follow the endothelial lining also, and then we are happy that this tumor plug is start to get this endothelial lining cover, and then we can safely call something like this as an invasive tumor into vessels as well. You see, this is so these are all various examples. It's just the PowerPoint today is not helping me for the speed. I don't know why it keeps freezing when I turn between the slides. But let's hope it will tend to get us the next slide in a minute. Here we go. This is the one that you need now to focus on this one. This is the invasion which you don't need attachment to the vessel wall. You do not need endothelial lining around the thrombus. All what you need in this is to see the fibrin, okay? And when you see the fibrin, this is an astonishing example of fibrin, but I wanted to put it for you. So when you see even a little bit, like very small areas, like in the corner here, just a blob of fibrin, then automatically speaking, if you think you are inside the vessel and you get any fibrinoid material, even if it is a very tiny, weeny little piece that you see around the corner of your slides, then I would strongly recommend that this is a vascular invasion. You see, this is the fibrin thrombi when you get it in adjacent to the tumor thrombi, and but this is very, very diagnostic, and I will never hesitate, even if it's not attached, it's just floating in the air. I will not hesitate at all to call something like this as a thrombus. Now, I will go through another example now here, and what you are able to see again, this bulge which are going through the vessels, this bulge here, which you see it through just bulging into vessels. These are not true invasion, so this is easy for everyone. But you can, what I want you to appreciate that how the bulge can change the color, the lumen diameter of a vessel, and then you will realize in the more difficult cases how it is. Okay, so this is another one. So this is the one that I get a lot of people calling gay cancer, a lymphovascular invasion, and this is wrong. This is not lymphovascular invasion. And I will tell you the references after I finish all the photographs. Okay, thanks for the question. Okay, but this is here is basically this is floating. There is no endothelial lining here. So despite the fact you can see the vessels very well, you see tumors inside the vessel, but this is not. So this is the one that you will ignore. Now we're moving to another one of those. Sometimes it is not, they can be cells, you know, they can be just scattered cells of the follicular epithelium, not definitely the thrombus that you see, but in absence of fibrin, this does not qualify based on the criteria for it to become a lymphovascular invasion. Okay, so it does not. This is another example of what I have shown you before, that you have good attachment to the vessel wall, and all what you need now is a little bit of endothelium around there, and then you will call this lymphovascular invasion. Here, what is the authors trying to tell us as well, here in this example of this picture, that you can see that you have a surface endothelial lining. What if you are to do your and you can see the attachment to the wall, okay? But again, we are still very confined to this. I just trying to enforce and make sure that the point is taken. I will, this is another bulge, unless if you get an endothelial lining here, this example, I will definitely do an endothelial to see if it is just pushing and distorting the shape of this vessel, or it is definitely started to get a proper endothelial lining, sometimes within here and within all the areas. But this is just to show you that example. This is another good example here of what you will feel that this is lymphovascular invasion. This is a plug that you wanted really to see, and this is classic for FRCPath exam. If we are to bring you a lymphovascular invasion into this, then this is what you will be faced by. This is, again, this can be inside a vessel or can be pushing. To me, I don't know, if I don't see any endothelium here, this is too wide base to be pushing into a vessel, like to just be like a mushrooming into a vessel. This is not. This is a very wide base here. And I think this example is just pushing the vessels and distorted its shape. So if you just walk with my arrow here, my laser pointer, you will be able to just follow the vessels around here. So this is how the vessel shaped up after this nest that you can see in the bloodstream. Again, pushing only into lumen does not give you diagnosis enough. This was a good example, and you can see that there is the endothelium here started to move and mobilize itself from the wall of the vessels and go up all the way to circulate the thrombus. So this phenomena, that's not going to happen normally. This phenomena for the manipulation of the endothelium to start to endothelize the surface of the thrombus, again, this is the immunophore. So this is what I'm trying to show you. The endothelial lining now twisted, and then turning around and taking all the shape of this thrombus. You can see here which is the one that you really need to look for. And this is the learning point of this slide, that you can see that the endothelial lining is still here, still present at the base of the thrombus. It's only has been perforated and lost where the thrombus or the invasion has happened into the blood vessel wall. It has just got one interruption here, but look, the endothelium is still all the way around. It is present, exactly like the caricature diagram that I have shown you at the beginning of this. So you will be fine. Now, this is very convincing for everyone for it to be a metastasis. You see a big nest of tumor present inside the vessels. The vessels has endothelium, but the thrombus is not attached to the wall. And you can see here that the endothelium is not really lining this. So this is the example where this is the false invasion. This can happen sometimes during manipulating the specimen through the cutting. It can be a carryover within or just floated within the vessels. Whatever it is, don't call this invasion. Although a lot of people I know, they will call this invasion. But again, when it will land on my desk, I can tell you I will never call this invasion. I might do the endothelial CD31 to make sure that this thrombus doesn't have any endothelial lining, but providing that doesn't have attachment to the wall, there is no point in calling it. Not every bulge is an invasion. And if the bulge is not lined by endothelium, like what you see here, just just find a better example, don't call it. Okay, so even with an example like here, even if the thrombus, the tumor thrombus, filling the entire cavity of the blood vessels, you cannot call this invasion unless if the endothelium is lining it through, or you see the area that's adherent to the wall where you will lose the endothelial lining focally. So you might lose the endothelial lining if there is a true adherence to the wall. But if you find that the blood vessels endothelium with the CD31 is intact all throughout, then the embolus is filling the vessels, but it is not adherent to the wall. And then your quest will be to the margins where you can see here, there is a little cleft between the vessel wall and the thrombus. And if this thrombus is not covered by endothelial lining, then I will say no for invasion. That won't be invasion, okay? Now the next here is another good examples of the carryover. This is again no. And what I told you before, you start to get the blood vessels even inside this thrombus. And it was very interesting comment from one of you last time that he said, oh, you can have it recanalized. Well, you can recanalize any thrombus. Yes, the tumor thrombi rarely can recanalize, but why do you need to recanalize this while the rest of the vessel is still patent? It doesn't make sense. Recanalize happens after a full or near complete obstructions, but let's not go there, okay? And this is another big pitfalls again for the invasion, because a lot of people get the delusion that this might be all a big thrombus inside a vessel, but the vessel here is quite distorted and compressed. And if you are to do the CD31, it will only be covering the blood vessels, and nothing, you will see nothing at the neck here of this lesion. There won't be any CD31 again attached to this. Be careful with the false vessels. Not everything or every cleft you see in the wall, you will be calling it vessel. And sometimes the fibrin can be difficult and tough to search for. And, you know, especially with a bad quality, it depends where you work. But if you work in a lab, which will give you a slide that's looking like this, everything here in this slide looks like fibrin. Okay, do then any special stain that can stain the fibrin. Some people in some labs even have an immunostain that can stain fibrin. Whatever you have, just do one of these Mason trichome or HVG or whatever stain that might stain fibrin. But what it is that people tried as well to talk about an areas like this one, and the basically like tried to say, oh, you can do also smooth muscle markers to see if the blood vessels has got a thick wall, because invasion, to be reliable, the vessel wall have to be muscularized. No, that's not true, because lymphatic invasion is still counted as lymphovascular invasion. But what is true in this method is the fact that you basically the fact that if it is a very small capillary and you would like to call it invasion, then I will stop you and I will say breathe. You know, I will not say go ahead and call it invasion. So I will just ask you to breathe a little bit before you really diagnose a carcinoma on a small cluster present in a capillary vessel. So this is just to highlight. Now, to answer the question of the summary, what I can tell you that these 20 or 25 slides that you saw now, some of them are mine, some of them are from textbooks. I used approximately 20 textbooks of thyroid in order to get you these pictures. You see, this is everything. This is everything that has been pictured in whatever, you know, like Rosai, Fletcher, and the specialized in the thyroid books. So we know the textbooks as references, and so I just saw that to make it a little bit clear for you, and I hope this will stick to your mind now with that diagram, and you will be feeling better. Now this case came in the exam before, okay, so this is a real exam case, and I will what I'm going to do for the next minute, I will just go around it, and I will need to see some suggestions, okay? And then we will start talking about it. So I will increase the power gradually, and I will just show you the lesion. And I know the screen, when I move it, might pixelate in, for some of you, but I'm trying also to move it very slowly to avoid this problem. And in the exam, you only have 2 minutes to see a slide and to make up your mind, because your writing will usually take about 8 minutes. You get past the case in double, and so 2 cases every 20 minutes. This is how it does work. And sometimes some cases might take longer, but you have to be very religious about it. 10 minutes per case means 10 minutes per case. And if you don't know and they haven't finished the case, you must move to the next case. You must. I kind of like got an alarm clock in front of me. You cannot put the alarm on, of course, but I got clock, got watches, everything, stopwatches, adjusting the 10 minutes to be religious, because if you took 2 minutes from the second case in the set, you will be rushing and you will start getting angry and agitated, and you will lose concentration and focus. Right, I'm going now to the higher power. So let me just make sure that you are seeing what I'm seeing, yeah? Okay, so I'm just going into the higher power. And I will stop here. Okay, so suggestions, please. Okay, some of you, don't be shy. There's some of you, like 3 or 4 suggestions, and then we start talking about the case. So we have got metastasis, we've got medullary carcinoma. Any other case, any other takers? Medullary. Okay, the dysharmonogenic, medullary and amyloid. Okay, fine, all right. So let me just show you a few things in this case, and then we will move on, because we've got a lot of cases also to review. The thing is that what I don't want people to do in the exam is to get any. You need first of all to stand by the low power and see if you have an encapsulated lesions or non-encapsulated lesions, because I told you that with the WHO analyzing adenoma as well, we've got this suggestion. So WHO is basically talking a lot about this new classification, FP and well differentiated or uncertain malignant potentials and things, adenoma, carcinoma, you know. So you need to decide very early on the capsule, and this is the #1 approach in any thyroid neoplasm. Because if you see a well-formed capsule, then that's well and good. If you don't see a capsule, don't make one. If there's no capsule, there's no capsule. And this is the first things. #2, Number two, that most of the neoplastic, either follicular or papillary or follicular carcinoma will acquire a different type of color from the background thyroid, and that automatically can also tell you I am a little bit neoplastic. But what it is, you can see within this tumor that you have these follicles, which does have colloids, okay? And this is why one of the things that you need to pay attention to if you really have these follicles in, because you need then to make sure that you're not going to discard the fact that the possibility that this might be still a follicular carcinoma. Just to keep that in mind. So I want you to keep that in mind, because we have these follicles which are filled with the colloid, which are present hand in hand with your tumor, okay? And if I am correct, and if you believe me, medullary carcinoma should not produce follicles, okay? But this is one of the big things that can put a lot of people off in the exam, because especially those who love high power, because once they see, they get very excited about the case and they go directly to high power, exactly like that movement, jerky movement, which I just did on the screen now, okay? So they go from very low power to very high power all of a sudden, skipping the fact that we have a lot of power magnifications in between the power 40 and the power 4. But they don't do that. They go to here, and guess what? They will start assessing the nuclear details for papillary carcinoma, and guess what? They will see a lot of pleomorphism into these cells, follicles again, pleomorphism, and then they will say, oh, it looks very pleomorphic. Then they will start seeing even inclusions. They start imagine some thermometers calcification, but then they will call it, they can call it then something follicular, or they think that in actual fact, you know what? I think that this might be a long trabeculae with elongated cells, and I think it might be hyanizing trabecular tumor or hyanizing adenoma of some sort, okay, but here is a very big clue. And with my very little experience, I almost always see the medullary carcinoma is to have this amyloid present in the background. If it is not present, that means that you did not take enough sections out of your tumor. But it's almost always this dense eosinophilic material that is devoid, it's acellular, and it has to be, there is no other thing for this to be. Hyanization must have fibroblastic proliferation, and this is not. This is in the context of this tumor is. Now, but why I wanted to stop a little bit by this, of course, they need to understand that medullary carcinoma can look a little bit polygonal and epithelioid, and this for me was the clue, because if you have a very widely invasive follicular carcinoma that's present within this, then the follicular carcinoma will not have a polygonal tumor that itself that's multi-angulated, as you can see in some of these cells here. So some of these cells which you can pay attention to, in this diagram has got this polygonal shape. Can you see that? It has got this polygonal shape with a lot, like four angles into this. Some of them will have 5 angles. The other things as well, the cells looks a little bit more amphiphilic, and this is a feature which people tend to describe a lot when they talk about medullary carcinoma. The medullary carcinoma is a tumor that tends to form a lot of these pseudocystic spaces, which can also be a clue. And some cases, I don't know if these cases has any, but sometimes even you might see some methane has been formed into this. Excellent points. Salt and pepper chromatin. Yes, we don't have it. Yes, we don't. The reason why we don't is because you applied the rule wrong. Okay. Now, tonight, when you are going to do your bedtime reading, if you are to do any, what I want you to do is I wanted you to open, for example, schwannoma. Yes? So I want you to open a schwannoma case. Easy, straightforward. A lot of neuronal cells in it. Yes? But why I'm saying that try the schwannoma case, because I wanted you to basically look into the cells and see all the cells really are showing this neuronal architecture. No, the truth is no. Okay, and I will put now this nest in the middle of the field, and I wanted you to look into the nuclei here. Number one, that there is no cells in medullary carcinoma normally, apart from some subtypes, and I will show you the subtypes in a second. But in medullary carcinoma, the cells don't look like brothers and sisters, okay? Even in the single nest, okay? So every cell in the nest is of the nucleus is of different size, different shape, different chromatin. And if I tell you, and you have to believe me, that the cells in the center of this nest are the salt and pepper ones. I cannot go higher power on this. This is only a scan slide, as you know. Salt and pepper. I will put the arrow against another one. Okay, another one here. Another cell. I just wanted to see if you can see this. Just 1 second. Yes, you can. So you can see my arrow now against that cell. And this is punctate nucleoli with a lot of clear areas around them and the granularity in the nucleus. This is again an example of a salt and pepper. Now, who told you before that there isn't a prominent nucleoli in medullary carcinoma? Who on earth have got the courage to tell you that, right? No, they did. They did, I know, you know when they did? I will tell you. They did when they were teaching you the new endocrine carcinoma, especially the small cell and the carcinoid, yes? They tell you that carcinoid and small cell carcinoma don't tend to have nucleoli. Yes, and we agree with this, right? There is no problems. You might find 1 or 2 nucleoli, but what is on the other contrary of the new endocrine that people tend to forget? At the end of the classification of the new endocrine carcinoma, you have something that we call it large cell new endocrine carcinoma. Yes? And the large cell new endocrine carcinoma, go back to your textbook or to the cases that you saw in the large cell new endocrine carcinoma and see does these cells have a prominent nucleoli, or does they have a smudged chromatin or salt and pepper chromatin? In actual fact, in majority of the textbook, what you will find that they have described this as a prominent nucleoli. And this is why a large cell neuroendocrine carcinoma, for example, will be a difficult case to diagnose. Okay, let's take this knowledge and bring it back to the medullary carcinoma. Okay, in this slide that you see in front of you, these are small cells or these are large cells? If you are telling me these are small cells, I will say no, go and revise again, because you can see that the nucleus here is nearly 3 or 4 times the size of the lymphocytes, or nearly 5 times the size of the red blood cells that present in the vessels around it. This is by definition a large cells. In actual fact, the salt and pepper phenomena is more that people relied a lot to diagnose neuroendocrine cytologically, not histologically, like on cytology. But one other features which I wanted to show you into that, because people, when they see, they believe, and I wanted to show you why the college, for example, showed this case. Number one, if you do not identify what's amyloid and what is not amyloid, then you probably can drift a little bit away from medullary. Number two, if you believe in the fact that nuclear inclusion can only happen in papillary, this one single cell that I put in the middle of the field, that was very random for me now, but I found a cell with nuclear inclusion here. Now, the third things, what is this? Okay, what is this that I am trying to circulate with the arrow now? Well, I hope that you're not on your mobile phone. This is thermometer calcification. You're absolutely correct. Okay, so you get thermometer calcification as well in medullary carcinoma. Here we go. Excellent. Now, one thing that you need to appreciate, and we talked about it before, and we will be talking a lot in the rest of the sessions, but one of the very important architectural features in papillary carcinoma is the nuclear crowding and overlapping. And look, if you really look into this here, into this these cells, they are very respecting each other. They are trying to stay away from each other with no real crowding or no real overlapping. The other things as well, which I wanted you to understand when you get a case like this, that the NC ratio is not very high in medullary carcinoma as compared to the follicular carcinoma and as compared to I don't see mean Hertel carcinoma, by the way, and but in relationship to the papillary, which should have a high NC ratio in general, unless if you are dealing with a special type like columnar cell change or tall cell, but this is it's not going to come in the exam. So let's not drift. So yes, now you know that prominent nucleoli can be a feature that you can see in medullary carcinoma and can see in Hertel cell neoplasm. You don't see that central nucleoli in papillary carcinoma, and you should not be seeing it as well in follicular carcinoma, even when the cells become ugly and malignant. Okay, the nuclei in the papillary and follicular tends to be a little bit more eccentric, not central. But in medullary carcinoma, one of the very characteristic features is these bizarre cells. And don't call it, don't run and call something like this anaplastic, because you start to see multinucleated cells, and you started to see some of these bizarre cells. Someone is asking, does Hertel cell come in the differential here? Helper cell carcinoma possibly, but you will need to appreciate the fact that you don't have you do not have encapsulation, first of all. The second thing is that you do not have the eosinophilic oncocytic cytoplasm. This cytoplasm is a little bit different. The pseudo cysts and the fact that in some cells, I'm trying to find a good one for you. You get you will get also some vacuolated cytoplasm. Look here, these cells. Can you see that cells over there? So these cells start to get some vacuolation in the cytoplasm. You know, this and this one as well. The cytoplasm is trying to become a little bit clearer and a little bit more reticulated, more vacuolated. This phenomena, we tend to see it more in the medullary carcinoma. So in the exam, if you're stuck, by all means, you know, the right things to do is to favor medullary carcinoma, and then you then basically say, I put the differential for hetero cells, but I favor medullary because I saw the amyloid, of course, and I saw the features, the polygonal shape, you know, this respection of each one space, so all of these features you have to put it in hand. The question is, can it form follicles? Well, it does form a pseudocystic spaces, but it doesn't. Let me just show you a nice slide here that I put at the end of my presentation, which is this one. It is basically what is it saying that these are the format of this, okay? So if it start to form a lot of these trabeculae and the pseudocystic spaces, then you have what we call it follicular / tubular pattern. This is not a true follicles, okay? This is not a true follicles, okay? It is a pseudocystic spaces or pseudo follicles, but because sometimes it catches your eye, so some people will call it follicular neoplasm. Of course, the follicles, which we saw them with colloids in the middle of the tumor, these were only entrapped tumor, and they were different. The spindle cell is what everyone knows about, but it doesn't come quite often. You saw that this one, when we got you that one, it's more looking more of squamoid, I would say. It has got some focal pattern. It can have the small cell pattern, like the small cell carcinoma of the lung, and it can look very much like a squamous cell carcinoma. But before you diagnose a squamous cell carcinoma for the exam in a thyroid gland, just think of what did I eat last night? Did I drink too much? Okay, so this is what you need to just highlight into that before you jump to this. I am yet to see one, okay? And I saw maybe hundreds and hundreds of thyroid now, but I am yet to see an SCC. I think it does exist. I saw it before in laryngectomy. I get a lot of laryngectomy with a cancer extending extra larynx and going into the thyroid gland. But the SCC in the head and neck tends to go more into lymph nodes. We all know that, okay? And it's not to go into this parenchyma. Now, before I leave this case, I just wanted to highlight into the fact that some people mentioned metastatic. Okay, absolutely. Okay, put metastatic, but don't jump to metastatic if you have not been given history. because you can say, yes, metastatic carcinoma come in the differential diagnosis, but I will still do the immunohistochemistry staining pattern to highlight this and know what is this all about. Now, what you need to write, by all means, I can tell you that now, and listen to me carefully with this, that if you telling me this is medullary carcinoma, and you run out of time because you kept describing, then I will, and you run out of time, you didn't write the immunohistochemistry or anything else, you will get 2.5 unsafe. I am yet, personally, as a doctor here working in the United Kingdom to diagnose a medullary carcinoma without immunohistochemistry. I simply don't. I still have to do my neuroendocrine markers, my calcitonin. The calcitonin usually will stain the cells as well as the amyloid, just to highlight for you this. And then you will be safe. So this is number one. You can also add in your additional point, additional work, Congo red stain. So that also will stain will mark you. So if you add the immuno and the Congo red, you go from 2.5 to become 3. Okay, that's even if you put a differential diagnosis, but you favored medullary carcinoma. Okay, you have to favor something. Every time you put a differential diagnosis, you have to favor something, or otherwise you get 2, which is the borderline fail. Even if your differential was correct, you don't pass. Now, what it is that, yes, and then you do the additional points. First of all, correlate it to the finding in cytology if you were given any categorization. Okay, so say this does not match the cytology, however, this can be a big pitfall. It's one of the most difficult diagnoses in cytology. It didn't come in the FRCPath as cytology. I think it came few times now as a histology, but it didn't come as a cytology. The second things what I want you to, what you can say is to talk about the MEN2, which is it can happen with it. Yes, exactly. So you say it can be sporadic, it can be multi or syndromic, and then you say that the genetic counseling sometimes might be required. The third thing is our data set, okay? And people tend to forget that, right? Because you wrote a description up, but you will be scored against this, you know? I would want it to see that you've read our data set from the college and you know what are the criteria. So we wanted the size. So if you need to be able to have a ruler or something to measure. This is not difficult to measure, and then you can TNM it, okay? So you can give me the measurement and you can give me the TNM. You will give me the completion of excision because you can see the ink margin here into this. And you will give me an information about the extrathyroidal extension into soft tissue. You will give me as well lymphovascular and perineal invasion. And you will give me the interface with the background thyroid parenchyma and the background. So what I am trying to say that you need to implement and write it down. I tend to say, I know a lot of people will write it in the micro description, but I tend to put it down in the additional information to make sure that the examiner will read it. So I write the sentence exactly like that. I will report this case as per data set item. I will include the size. You will measure on the slide, okay? So just measure on the slide, yes? So just, you know where is your tumor now, so you just get it out and put your ruler on the slide and measure it. Just give a rough measurement. you will be absolutely, you're not going to be penalized for that, unless if it is 1 centimeter and you said 40, then I will penalize you. But if you said 1.5 and it's 1, that's fine. Okay, so back to that sentence that I will do. So this is what I will write. I will report these cases as per data set items, and these are as follows. Okay, and then I write them down. Now, I cannot remember if I told you that before or not, but let me just tell you a little bit of information about the exam booklet. Okay, you can have as many booklets as you want, okay? And it is better to leave a line in between in your writing. So when you are practicing now, I would ask you strongly to get this lined A4 paper, university style, with 2 columns on the side, okay? So the paper, the exam booklet has got 2 columns on the side of the page that's taking nearly like 10 or 15% of the volume, and you are not allowed to write outside the column. If you write anything outside the column, it will not be counted in your marking, okay? So what I mean by this, that if you have the habit to write immunohistochemistry for this and you write it in the lines on the outside, you know, like, you know, when the pages is divided with 2 columns on either side, this is what I mean. If you write outside these columns, any information you write outside will not be counted in the marking. What will be only counted in the marking is what's inside. Because the reason for that, because to avoid any bias, just in case if you are the son of the examiner and the examiner waiting for your sign to say that you always write outside the column, then I can identify your paper and pass you. So the college consider this as identifiable, and anything you write outside has to be ignored. Now, as I told you, now you will need to leave a line, and that means, because if your writing is very, it's not a nice and neat handwriting as most of us as doctors are, and you don't leave that line in between your writing, then it will be very difficult to read, and you are not going to do a favor for yourself. So leave that line, but you need to practice on it. Because if you don't practice on it, it is very simultaneously, you will find yourself not leaving that space. So this is another tip I wanted to highlight. The third one, which is a very important one, but this is not for those who are going to sit the exam in a month or 2, okay? It's too late to practice on this. But if you are going to sit this exam in a year, then do this, what I'm going to tell you, do it, because it will save you a lot of time in the exam. What I want you to do, okay, you start the question with a new page. So leave that page and move on to the second page. So your first page, which you left blank, that's your microscopic description of that case, right? What you need to do then in the second page is to write your diagnosis. That's your diagnosis and differential diagnosis case. Okay, if it's one diagnosis, then absolutely carry on and do what you wanted to do underneath that as additional work. Okay, and then when you go to the clinical pathological or additional points that you wanted to add in your case, then what you need to do is to move on to a new page now and write it. What will happen now, you spend 2 minutes, okay, 2 minutes for getting the diagnosis. You got the diagnosis and you build up the differential diagnosis after the first 2 minutes, and then you start writing the diagnosis. That will take about a minute or 2 with the differential diagnosis and why not and why it is yes or no and why, okay? And then if you are going to put any immuno, might take you another minute or so, And then for the clinical pathological correlation, like for example, in this case, you have MDT to write about, you have MEN to write about, you have prognosis to write about, you know, all of those sort of things you will include in your additional points. And then cumulatively, you will find that you would be left now with 3 points, with 3 minutes. Now, the 3 minutes, you will go back and write your micro, but now you are not thinking, because everything about this case is already in the back of your mind. So you just say nested pattern of growth, dense hyalinized stroma with amyloid deposition present in between. The cells are polymorphic and pleomorphic. Prominent nuclei seen, bizarre cells, and then it looks focally infiltrative in surrounding parenchyma. And then that's it. You see what I mean? That your micro didn't need any thinking now. I didn't think at all, okay? But that will give you a lot of relaxation of the mind between every case and the next one. The problem which I find people happen sometimes in the exam, that if you run out of time, you know, imagine if you run out of time, you cannot go back and write an immunotable or immunohistochemistry because you're rushing. You cannot do that. Okay? Yes, you can ask for 5, 6, 7 sheets. No one will tell you what you're doing. Okay? You can ask for as many sheets. So this is but what will happen is if you're rushing. If I am rushing, let's say I'm rushing now in this case, I have only 30 seconds. 30 seconds to write my micro on this case, okay? Then I can write it. I can definitely write the micro for this case in 30 seconds because everything else, data set items and everything else, I have already mentioned those later. So all what I need to say, nested tumor, intrathyroidal, non-encapsulated, infiltrative, bizarre cell pleomorphic cells, amphiphilic cytoplasm. That's it. It is 1.5 line. What I said, you can definitely spend 30 seconds to write that. As I said, the problem is, I was invigilating many times in exams in FRCPath. I saw what the people tend to spend an hour, like the first 4 or 5 minutes, writing the micro description on a whole sheet of A4 paper, describing the weird and wonderful things that they saw in this tumor. Who cares? Who cares, right? All what you need to tell me that you defined that this is a malignant tumor. Solid, nested, infiltrative. This is the common language that we all use across the world. This is what we wanted to hear. If you start to describe to me cell by cell, what a waste. What a waste of time. The reason why I'm showing you cell by cell, because it will help you in the future as well. And it will be very good for your progress in even cytopathology, because now you know that the medullary carcinoma can have a lot of bizarre cells, pleomorphic cells, prominent nuclei, blah, blah, blah. So if you get it in cytology, your biggest enemy in it is the anaplastic. And they can look exactly like each other, medullary carcinoma and anaplastic. And without having the modality to do immuno, there's no way you can say. You have to tell them what the calcium level is like, you know. Here, for example, you will talk about a little bit about calcium in this case. You can talk about the calcitonin level. You know, all of these things are bonuses. All of these things you naturally, you know, as a doctor, you know it. And you can mention this. the major data we have in the data set. So the question is which point we will mention out of the data set. In the data set, when you open it, you will find out if you don't want to read it because you're running out of time, your exam is after a month, after a day, and you didn't read it, just open the final page and you will find that the college has put the pro forma of what's needed in the report. But anything from what I mentioned, the tumor site, the TNM, lymphovascular invasion, extrathyroidal extension, completeness of excision, all of these are data set items that has to be mentioned in the report, okay? So try that technique that when you do a mock for yourself or sometimes it's testing you, leave the first page for your micro and start with diagnosis, differential diagnosis, additional work, and then additional information section, and then go back to the micro. I want you, when you do the mock against time, see how that will affect your brain relaxation. You know, you will find that every 2 or 3 minutes, your brain is getting very, very relaxed and fine. I think I wanted to show you a lot of cases. You know, I have 10 cases open up here that came in the exam, but I am going now to show you just quickly now the cases that came in the FRCPath, and I will show you some similarities for the next 10 minutes. So you can put your tea down, your popcorn down, just stare at the screen because we will move very quickly in this group, and then we will show that in details. I will arrange on a different platform some thyroid teaching, and I will in a very comprehensive, very comprehensive. That's not particularly exam orientated, but it will be universal things that we will arrange. This is a classic case that we see it in everyday pathology, and this case is basically a papillary carcinoma, which is very small. So this was only a micropapillary carcinoma that came in a background of a normal thyroid. So I'm just showing you the cases now that came in the exam. I'm not going to go through them because we are running out of time, and I know that we have to be a little bit religious about it. This case, another thyroid case in the exam, this was a sample that's taken from scalp, okay? And as you go, you see the follicles. Automatically speaking, this is a follicular carcinoma. Now, if you're not sure because you start to imagine nuclear details, just tell me metastatic, well differentiated, okay? But if scalp is a common site for this, the problem was that you have to be sometimes in the right mind frame that what you see is a thyroid in abnormal place. So this was an easy one I would consider. So this is another case that came. I will go, this is another one. This one was taken, I think, in, yes, I remember this, yes. Look, this was a 90-year-old or something, 80-something, and it has got this nodule in the thyroid gland. And let me just try to bring it to you guys in focus. Yeah, here it's gradually focusing. Okay, so you can see that this is a different population, okay? The last case which I showed you, fragments and fragments, was a metastatic follicular carcinoma. Okay, so this case now is different. You have this nest, the cells are, the cytoplasm clearing, reticulated. So this will come under the heading of this clear cell tumor that comes into in any place in the body. Okay, so if I was to give you a case like this in a young patient, you probably have to think of the seminoma groups, but yes, in the old age you will think of RCC, which is very common, renal cell carcinoma, which is very common to metastasize into the head and neck region, lymph node, and even into the floor of mouth. Now, adrenocortical tumor is a very rare carcinoma, is a very, very, very rare tumor. If you wanted to put it number one, you will be killing yourself. But this is a good suggestion. Intrathyroidal, parathyroid adenoma is definitely yes, yes. I will put definitely that in my differential diagnosis of that case. But yes, this was a renal cell carcinoma metastatic. This case was lymph node. You see, I just wanted to show you sometimes how easy it is, the cases in the exam. Paraganglioma is fine as well. You can put that in the differential diagnosis. But don't forget, we are talking about this, the history really, they didn't give you the history of renal cell carcinoma in the real exam, but in a very elderly patient, just to think as well of the renal cell or metastatic, because that is more common around this age. But yes, I agree. I told you in the exam, if you are to tell me this is renal cell carcinoma and you don't do the immuno and you don't do the differential for all what you've mentioned, guys, now, I will personally get your paper and fail you, because we do not diagnose this without history and without immuno and without differential. This will be madness, okay? So don't. This is another case, that's easy one. This were lymph node, and you can see that the papillae, and this is a metastatic papillary carcinoma. In this case, this is a different one. Again, this bluish tinge, I will only get you on the high power on the middle of the slide, and you can definitely see this, which is very similar to what we have seen before, okay? But you can see the cells here a little bit more spindly, the architecture is a little bit different, a little bit more clearing. For those who are not big fan of nucleoli in medullary carcinoma, this is a second case now, and look, there's a lot of prominent nucleoli. So now you believe me, now you believe the college. Yes, we put it because a lot of you feel or have the belief that prominent nucleoli take medullary carcinoma out. No, now you know that all of this group of cells in the middle of the field has got prominent nucleoli everywhere. Okay.